Hi, thanks for joining us again for episode number 99 of the Doctor Podcast Cykiert File Show. And today we have a very important episode. We're going to be talking about the aging spine and techniques in maintaining spine health throughout life. I'm an ophthalmologist, but many of my patients complain to me all the time that they have back problems and spine problems. So it's a very common thing, especially as you age. And today I'm really pleased to have an expert in this area. It's Dr. Gbolahan Okubadejo, who is a spine surgeon and an expert in this area for many years. He graduated from Johns Hopkins School of Medicine in 2002. He completed a residency in orthopedics in 2007 at Washington University, very prestigious university. He also did a fellowship in spine surgery in 2008, and he's been in practice doing spine surgery and taking care of patients who have spine problems for about 17 years now. And he specializes especially in minimally invasive spine procedures and robotic surgery, which we'll talk about some more in a little while. So thanks very much, Gbolahan, for joining us today. I really appreciate you taking time from your busy day and schedule to do this. The audience loves this type of information from experts.
Absolutely. Thanks for having me. It's my pleasure being here today.
So tell us what got you interested in orthopedics after medical school, and then specifically why you subspecialized in spine surgery.
So my interest in orthopedic surgery actually began prior to medical school. I've always been interested in athletics. I was always interested in medicine, and I was looking for the best way to merge my interest in athletics along with medicine. And to me, the natural fit seemed to be orthopedic surgery. I shadowed orthopedic surgeons while I was in undergrad to just get a full sense of what the field was about. And after getting those experiences, I was convinced that that's what was the right field for me. During residency, we rotate through every portion of orthopedics. We do sports, we do spine, foot and ankle, tumor. I was just drawn towards spine. I enjoyed the complexity. I enjoyed the fact that there is science involved. Um, it's not a one size fits all. For any diagnosis or for any clinical presentation, there are multiple things that could factor into what's causing the patient's pain. So I like the fact that I have to figure out exactly what the pain generator is. There are different treatments that can be offered. It's a field that constantly is evolving. It keeps me stimulated. And when patients do well, the gratification is there are no words for how gratifying it feels when you get a patient out of pain and functional.
Right. Yeah, I talk to my patients, as I mentioned, when somebody helps them with that, they are so grateful. So,
Absolutely.
how many years of training is that after the 4 years of medical school? How many years of residency and then fellowship did you do to become a spine surgeon?
So most residency programs in orthopedic surgery are 5 years. So the first year you do more general surgery just to get the lay of the land, to get your hands going, kind of getting your surgical skills going. And then beginning the second year of residency, that's when you start to really get into orthopedics. And as a junior orthopedic surgery resident, you do a lot of observing of your attending and of the senior residents to learn the techniques, to learn the language, because it's a completely new world to us. The language is
Right.
completely new, and it's very technical. So that's where it's a gradual process of first learning and observing, and then getting your hands involved, and your confidence builds over time. And it's just a perfect way to get into a field, to get educated both academically and technically. So the process of getting educated through orthopedic surgery is 5 years. And then after the 5 year period, some people go into practice and they become general orthopedic surgeons. If you want to specialize in something specific, they do a fellowship. So my fellowship was in spine surgery, and I did it at University of Pittsburgh. The unique thing about that program, it's very hands-on. It's a very busy program. So I got a lot of experience getting my hands onto spine and seeing the different pathologies and really getting comfortable. So my confidence grew throughout that period of time. And in 2008, I was ready to fly.
Wow. How many years was that, the fellowship?
So fellowship is 1 year. So residency is 5 years, and then the fellowship is then 1 year.
So only 10 years between medical school, the
Only 10
residence,
years, exactly.
only 10 years. That's good. But at that point, you're an expert and you have great confidence and you can do good things for your patients.
Absolutely.
So I mentioned earlier that a lot of my patients, especially elderly patients, have back pain and spine pain and are always complaining about it. Tell us how the spine ages and what are the common ways that a spine will demonstrate the aging process.
So the aging spine is very personal to me. I've always been very active, and as I get older, I'm now 50. I feel in myself my body changing. So I have a personal vested interest in learning how the spine ages and how to age gracefully. So as I tell all my patients, especially my older patients, when we're young, our spine, everything is ideal. Our discs have perfect height. In the cervical spine, we have what's called lordosis. Thoracic spine, we have kyphosis. And in the lumbar spine, we have lordosis. All the angles are perfect, the discs are perfect. And then based on our activities and some genetic predisposition, things start to change. So the way the spine ages, think of it from both the perspective of the bone and the disc. Most people think about the disc. So the first thing is a disc loses fluid, so a disc degenerates. As the disc degenerates, it becomes harder. So it has less buoyancy. And the less buoyancy that a disc has, the more vulnerable it is to injury. And that's typically what causes the herniation. So the typical thing that we see is a disc first changes. And if you look at an MRI, the signal, especially in a T2 weighted MRI, goes from a bright signal to a darker signal. So that's a sign of a loss of fluid. So as the disc loses fluid and becomes less buoyant, then the body has a natural reaction to try to preserve some stability. And it does that by forming bone spurs. If the bone spurs occur within the canal, then that can then put pressure on the nerves and cause issues. The bone spurs can also be seen in the facet joints in the back, and that can also cause pain. So that's the first thing you see. And as the disc collapses, you can have herniations, you can have bulges, the bulges also contribute to the space within the canal narrowing a bit. Another thing that's seen as we get older is that there's a tissue behind the nerves, behind the thecal sac, especially in the lumbar spine, called the ligamentum flavum. So the ligamentum flavum can also thicken. The people who are most vulnerable to having symptoms are people who have more naturally narrow canals. Some people have what's called congenital stenosis. If your if your natural formation of your canal is a little narrower, then you're a little more vulnerable to having symptomatic changes as the body ages. So, and other people get other types of changes where they have instability, known as spondylolisthesis. Some people have changes in the coronal plane, known as degenerative scoliosis. So those are the different ways that we see the spine changes as we get the spine change as we get older.
Right. So the curvatures of the normal spine that is supposed to have certain curvature, different areas change, and so the bones actually rub against each other because the discs are degraded.
In extreme cases, yeah. In extreme cases, you can have bone on bone where the disc is completely gone and you've got no room and the nerves are compressed, and that causes either pain that's axial, which is primarily in the back, or radicular pain that travels down into the legs.
So these discs are sort of like a ball that's slowly becoming deflated and not supporting the rest of the spine.
Exactly, exactly.
Hmm. So what are the implications for function that a person would get when this starts to happen? And when does it usually start to happen? What age group do you see that in?
Actually, you can see it as early as 30, honestly. Like
30.
people yeah, if you're very active, if you did a lot of sports when you were younger, if you did a lot of labor, then your spine degenerates a little quicker because the biomechanics that it's seeing from stress then dictate how quickly things change. So I'd say from the 30s on, that's when you start seeing degenerative changes. It's more in some people than others. The first thing you might see is some axial pain, and that's axial pain is pain that's primarily in the lower back. Um, and that pain occurs as the disc degenerates, the disc becomes a little stiffer, nerve fibers and vessels actually grow into the disc as it changes, and that makes the disc a little more vulnerable to pain. Posteriorly in the facet joints, you also have changes in the joints that can lead to bone spurs. You also have nerves that grow into the joint that can cause pain as well. So that's the first thing you see is pain. As pain and stiffness progress, and you may have compression of the nerves, then you start having pain that travels into the legs. So when people say I have pain that shoots down my leg, which they describe as sciatica, then
Right.
that's really a result of that compression. And then from there, as some people get older, the entire canal then can get constricted where you have stenosis. You might notice in some older patients, they can't quite stand straight, right? They tend to lean forward, and that can occur for two reasons. One is if your canal is getting thinner and there's less room for your nerves, and you get something called neurogenic claudication. And that's where the compression of the thecal sac within the lumbar spine affects you to a degree where you have to bend forward to get more space for your nerves, and that makes people feel a little better. So that's called the shopping cart sign. That's an extreme sign of stenosis. Another thing you might see, especially in some older ladies, is that especially the thoracic spine tends to curve a little more, or they're a little more kyphotic. You kind of have that form where you kind of hunch forward. And that occurs from degenerating spine, also from the bone becoming more osteoporotic, and they get microfractures, and then they tend to kind of stoop forward. So those are the different ways that it manifests as we get older.
Right. Now you mentioned pain several times. Everybody's had back pain from time to time. Sometimes it's mild, sometimes it can be severe. How do we know when we need to see a spine specialist like you? What type of pain is a signal that you better go see your doctor, as opposed to pain where you can just take some ibuprofen or Aleve or Tylenol and wait for it to go away?
So I characterize pain as being strictly axial, where I will focus on the lower back right now. I won't even talk about the neck currently. So if we're focusing on the lower back, if the pain is just in the lower back and it's not traveling down, you have no sciatica, you have no what we call radiating pain, then if it's persisting, you've seen your primary care doctor, you've tried ibuprofen, nothing's helping. Perhaps your primary care doctor has put you in physical therapy and that pain is persisting, it's affecting your quality of life. That's the time when you should see a spine specialist, either pain management or a spine surgeon, to give you some guidance. More concerning is if you have pain that travels. So if you have pain that travels down your leg and it's affecting your quality of life, if you start having numbness or tingling, you start having weakness, then you should prioritize seeing your spine surgeon so we can make the diagnosis and employ the proper treatment at that time. The most concerning presentation of spine issues is if you have bowel and bladder. So if you have bowel and bladder symptoms along with weakness, that's called cauda equina syndrome. And that's actually an emergency. So if you have that, then uh, you almost have to go to an emergency room first before seeing a spine specialist in the office, just in case something has to be done immediately.
I see. So that could be something pressing on your spinal cord that needs to be fixed right away.
Absolutely. Absolutely.
All right, good to know. So if the pain is very localized and not severe, then you give it some time. If the
Absolutely.
pain starts spreading from that initial focal point, or if you have any other symptoms like numbness or tingling or weakness or bowel or bladder loss of control, then it's urgent.
Absolutely.
That's great. So now that we know what happens and what goes wrong, and again, it's different in different people based on your genetics and your previous activities, what can the average person do to try to maintain their spine health and prevent their spine from aging or at least slow it down?
The first thing to do, actually, the best way to prevent your spine from becoming an issue as you get older is to prioritize it while you're younger. So,
Right.
getting into a good exercise routine, having good core strength, maintaining flexibility can go a long way to having a healthy spine as you get older. Be aware of your body and yourself. If you have aches and pains and you haven't been as active, get into the gym, get a trainer. If you feel you can't motivate yourself, maybe ask your primary care doctor to put you into physical therapy because then a therapist can locate the areas where you're deficient and give you a personalized program to get you on track. Um, an important lifestyle choice that can contribute to back pain is actually smoking. So if you smoke, then your vulnerability to back pain worsens because with smoking and tobacco, there's less blood flow to your discs. And if your discs have less blood flow, then you're more vulnerable to having back issues. So it's very important to realize how your lifestyle choices can also affect how your body feels as you age. So not only is smoking bad for your lungs and other parts of your body, your eyes as an ophthalmologist,
Right.
it's also bad for your spine. So that's something to consider. And also diet. So have a diet that's good, high in calcium, high in vitamin D. Those are vitamins that help bone structure, keep your bone as strong as possible. There's a portion of the population that's vulnerable to osteoporosis. So in addition to disc issues, bone issues are actually a major factor in spine health as well, especially in older, thin women. So if you're younger and thin, then you're more vulnerable. Perhaps get a bone density test, at some point just to see where you are, and you can start a program earlier rather than later, so you don't start having the issues before you have a chance to treat them. So consider both your disc and your bone as you age, and do things to preserve and be as healthy as possible.
Right. Now you mentioned exercise. Exercise is good for everything that ails us. What specific exercises? Like, for example, is running good? I run a lot. Some people tell me, oh, that's not good for your back and your knees and your hips and so on. But for me, it works well. So what are the best exercises and what exercises should be avoided?
Running is great. However, running alone is not enough, because in order to maximize your bone density, you have to have some resistive training as well. So it's important to combine both aerobic activity with weightlifting and resistance training. Most importantly for your spine, especially your lumbar spine, is core strength. So I've had a very personal interest in maximizing core strength. Um, Things that don't cause bending of the spine as you strengthen can contribute to core strength without overloading the spine. So meaning if you do leg raises, either on the ground from a flat position or raised leg raises, that's a wonderful way to strengthen your core. There are many different devices that now are in existence that you can use to strengthen your core. Traditional crunches and sit-ups are great as well. So the stronger your core is, the more stability your lumbar spine has, and the less likely you are to have pain just from natural degeneration and lack of posture.
So sit-ups are good,
Sit-ups are wonderful. Sit-ups are wonderful.
even though they don't feel that good when you're doing them. Your spine will love you if you do the sit-ups.
Absolutely.
So,
Sit-ups are not only good cosmetically in terms of having a nice six-pack,
right.
they're also very healthy for the spine. So
Wow, that's awesome. So if you do sit-ups and run, you've got everything under control. That's great.
you're on the right track, yes.
Right. Now you mentioned the diet and calcium and vitamin D. That's good. What about weight? Do are people who are overweight or even obese more prone to getting spine problems?
Yes, yes, because the more you weigh and the further you are beyond the ideal BMI, the more stress there is to the back. There are actually studies that show that your back sees the extra weight that you carry at a three times variant, meaning if you're 100 pounds overweight, your back translates that as being 300 pounds overweight. So weight is a major contributor to back pain. I've had patients who come in who are clearly overweight, and their MRIs are perfectly normal, and they have pain, and they're not quite sure why they have the pain. And I always speak scientifically, and I speak in terms of BMI and what your BMI should be given your height. And I let them know that the closer you are to what your BMI should be ideally, which is closer to 30, the more likely you are to have less pain. And hopefully, they take that to heart and make the appropriate lifestyle modifications.
Right. That's difficult for many patients, but now with Ozempic, Wegovy, and those drugs, many of my patients have lost a lot of weight, and
Yes,
so that's actually good. So
yes.
now, short of surgery, surgery is always kind of the last step that you do to treat spine problems. What non-surgical techniques or procedures or things that you do for your patients?
So the first thing, as I mentioned, lifestyle modification. If you come to me, you've had persisting pain, you haven't had physical therapy yet, I'll get you into physical therapy. The therapists these days are wonderful. They have many techniques that they use. They individualize programs for patients. So I get patients into physical therapy. If in spite of therapy, your pain persists, then we go into things that are a little more invasive, such as pain management. Pain management specialists have different types of injections based on what your exact pathology is, and the different injections that they do to target the areas where the pain's coming from. If with pain management and medication, primarily anti-inflammatories, we can get your pain under control and get you back to your life, then typically that's all that a patient needs.
That's great. I want to ask you, I see commercials on TV all the time about different mattresses. Seems like there's like 100 different mattress companies. They all claim they're the best for your back. Are there mattresses that are better for your back? Does it matter how hard or soft they are, or is it basically an individual preference?
It does matter. However, the mattress alone does not dictate how you feel. It's also the kind of sleeper you are. Some people
Hmm.
are stomach sleepers, some people are side sleepers, some people are back sleepers. So the different way that you sleep determines actually what mattress is better for you. Across the board, typically, a mattress that's more firm tends to provide more support. It's also important for patients to know how old their mattresses are, because if you've had a mattress that's beyond, say, 8 to 10 years, it might be time to change a mattress. So have a firm mattress. Look at the age of your mattress. Consider what type of sleeper you are. There are many mattress stores that actually customize mattresses for patients. So you go in, they'll have you lay on a variety of mattresses and see which one is best for you. But the ones that are firmer with more support, maybe just a little give, are the ones that I feel are best for most people across the board.
Good to know. Now, what about the posture issue? Again, I'm seeing ads on TV for all sorts of devices that kind of pull your back while you're on a computer, and everybody's kind of hunched over their computer or their phone these days. Is that bad posture harmful for the back, and what can you do about
Bad posture is absolutely harmful. It's harmful for
it?
the
Hmm.
neck. It's harmful for the thoracic spine. It's harmful for the lumbar spine. What matters more than a device is actually the kind of chair you use. So, the same way you consider a mattress that's comfortable, you have to consider a chair that's ergonomic. If you're having back issues from being still for too long a period of time, then stand up. There are standing desks that some people use as well. So
Yeah.
that can help you from leaning over. I'm actually against using a device that artificially gets you into the proper posture. Posture comes from being aware. So you have to have postural awareness. So be aware of your posture. Make sure you sit properly. Make sure you strengthen your muscles appropriately. That's a way to govern how you sit and how you feel, more so than an external device.
So sitting properly, does that mean you want to be straight up and not kind of hunched over on your computer or
Yeah,
laptop?
you definitely do not want to be hunched over. There's a phenomenon known as tech neck, where people are not aware that they're hunched over for hours at a time. That puts a lot of strain on the posterior musculature of the
Hmm.
cervical spine, and that causes a lot of discomfort. Or just being posturally in a bad position can also cause pain in the lumbar spine. So have postural awareness. I've written on this in the past, and what I do is I tell people to have maybe alarms set, maybe every 2 hours or so. If you're having issues, maybe even less periods of time, just so you're aware of when you should shift your position and maybe get up and stretch. But be aware of your body and what you're trying to accomplish. And I think the more postural awareness you have, the more you can take control over how you feel.
Do you like the stand-up desks that they're advertising now, where you don't sit, you actually stand up and use your computer that
I
way? Is
do.
that that
I do, yeah,
helps?
because a stand-up desk automatically means that you have postural awareness. And if you're standing and working, then you're more likely to take breaks, to walk a little bit, to do some stretching. Standing is more active than sitting. So standing alone can help you burn calories. So
Right.
typically, yeah, as a surgeon, I do a lot of standing myself. So I'm in favor of things that are active.
So sitting is like cigarettes almost, huh?
For some people, yes.
Right.
Yeah.
Now, once the more conservative measures have failed and the patient still has problems and they need surgery, what are the most common surgical procedures that you use to treat various pathologies or abnormalities of the aging spine?
So the procedures have actually advanced over the years. From when I completed my fellowship in 2008 to now, there's been a dramatic evolution in our options. Endoscopy has become a lot more of an option that we didn't have before. So if you have primarily axial back pain, then we can do endoscopic procedures such as endoscopic rhizotomy to help with that pain. If you have a focal pathology coming from a single disc, based on where it is anatomically, then we can use endoscopic procedures with a little camera to get that disc to relieve pain. If the pathology dictates what we do in terms of the solution. So if an endoscopic option is not appropriate for your anatomy, then we can do mini open procedures where we can work with a tube and a microscope. If that's not appropriate for your pathology, then we go into more open procedures. When it comes to open with the spine, especially the lumbar spine, we can approach things anteriorly, laterally, anterolaterally, posteriorly, almost every direction to get to the spine based on the level and the pathology. So almost everything you can imagine is now an option, and it continues to evolve where we're becoming more efficient and better at getting our patients up and moving quicker after surgery.
So better results, quicker recovery, basically.
Yes, yes.
Can you, for people out there who don't understand the term endoscopy, could you explain what that is and how you use that and how it's
So
different from what you used to do, let's say
absolutely.
15 or 17 years ago?
Absolutely. I think everyone's familiar with arthroscopy, right? You've heard of arthroscopy for a knee, arthroscopy for a shoulder, where you go in with the camera and you're going through a portal to visualize. So in spine, now we have endoscopic techniques where we make little holes, we go in with the camera, we visualize where the pathology is, and we use devices to debulk, typically disc herniations, if it's a disc issue, to take the disc off the nerve, and that gives you relief of pain. Endoscopically, we also do a procedure called rhizotomy. Now, a rhizotomy is actually a minimally invasive procedure that focuses on the facet joint. So if a patient has primarily axial back pain, there are little nerves that come off the facet joints that then become pain generators. So we go in endoscopically, and then we cauterize those nerves, and patients get tremendous relief from that. And that's an option that wasn't there years ago. So I've used that in my practice for over the last decade. I've had tremendous results. So the clinical presentation of a patient determines the options that we give them for treatment, and the options are always individualized.
Right. Now, I mentioned earlier that you also specialize in robotics. So can you tell us how robotics has become useful in spine surgery?
So robotics has been evolving within spine surgery. Initially began with navigation, where we use external tools to visualize things anatomically real time in the OR. Typically, it's been for placement of pedicle screws. That's the use of robotics. So we do preoperative imaging. We mirror that with the imaging that we're seeing in the OR fluoroscopically, and we're able to see the anatomy and more accurately place our screws when we're doing spine surgery. So robotic screw placement is when, with the robot, we have a guidance system to place our screws anatomically truer, which gives us more accuracy. Another way that robotics has also evolved in spine surgery is actually placement of the cage when we're doing fusions. So when we do interbody fusions, some companies now have the option of using robotics to get into the disc, place your cage for more accuracy. But it's even more exciting because it keeps evolving. So now we have techniques where we actually can use goggles, augmented reality, to
Mm.
actually
Wow.
see, pinpoint where you are anatomically in the OR, to place screws to see the anatomy. So it keeps evolving. And with artificial intelligence, the sky's the limit.
Right. Are robots ever going to put you out of business?
No, no, no. Robots will never be smarter than a spine surgeon.
Yeah, after 10 years, I mean, the robots have to go to school for at least a few years before
Exactly,
they
exactly.
do
Yeah.
that. That's,
Robots have to go through residency and fellowship first. So let's see how they do with that.
that's very interesting. Now, I know there are different types of spine surgeons. There are some neurosurgeons that do spine surgery, and you're an orthopedic surgeon that does spine surgery. Are they roughly equivalent, the same type of training, or are certain spine conditions better treated by orthopedists versus neurosurgeons?
The big difference between an orthopedic spine surgeon and a neurospine surgeon is that a neurospine surgeon within the spine can do things that are intrathecal, meaning if you have a tumor within the spine, then a neurosurgeon is, uh, I'd say, more appropriate to get that
So
tumor
if there's
within
a
the spinal.
tumor like wrapped around the spinal cord, the actual spinal cord.
Correct, correct. Yeah, that's really the main difference is that neurosurgeons go intrathecal, whereas spine surgeons, we typically focus on the bone. So, decompressions, pedicle screw placements, that's equivalent. However, if you have intrathecal pathology, then a neurosurgeon would be the one to address that.
I see. All right, that's interesting and good to know. But you first have to have an MRI or other scans to determine what the abnormality is, to
Correct,
determine who the best type of surgeon might be.
correct.
Now, where is your practice located? I think it's in New Jersey and New York. What areas are you in?
My main office is in Englewood, New Jersey. I also have a location in Jersey City, and I have locations throughout New York City, pretty much in every borough.
Wow, you're a busy guy. Thanks for taking the time to do this with all
Absolutely.
that. Is there a website that patients can go to learn more about back and spine problems and more about your expertise?
Yes, my website is nynjspine.com.
That's easy. New York, New Jersey,
There you
spine.
go. There you go.
That's great. Now, how can people in other parts of the country find a good spine surgeon? In New York and New Jersey, we obviously will go to you with your great expertise and knowledge. But what about if you're in other parts of the country, especially in let's say more rural areas where you're not near major medical centers like New York City? How would somebody look into that and figure out who to take care of their problem?
If you're in a rural location, then I would look at more academic centers. There are excellent academic centers pretty much in every state, and that's where the most complex spine surgery occurs. So if you're in a rural center where you don't have private spine surgeons like myself, then I would look at the university hospitals, and you'll get tremendous care at pretty much any university hospital in any state in the U.S.
So you're best off going to some hospital that's affiliated with a medical school or a major medical center.
Correct, correct.
Good to know. Any other key suggestions for the audience in trying to maintain and preserve spine health?
The most important message I have is it's never too early to be mindful of your spine. So if you're mindful of your health, then you're mindful of your spine. And also be aware of your activities because if you lift something the wrong way and you have a disc injury, that one incident can change your entire life. So I always caution my patients the first time I meet them, if they're having back pain, but it's not too severe, to be aware of how they lift. So biomechanically, you don't want to put too much stress on your back by having your knees locked and lifting with something too far ahead of you. You want to make sure that you're bending your knees and avoiding too much stress to your back. With your workout routines, put a lot of emphasis into core strengthening, have postural awareness. That will then facilitate you having a healthier spine. There's nothing more debilitating than back pain. So
Right.
prioritize your back when it comes to your fitness routine. Work on flexibility, work on bone density by having a good nutrition, be aware of your habits, including smoking. And if you consider all these factors, then you're bound to have a healthier life overall.
And stay away from you then, right?
Ideally, you want to stay away from me surgically if you don't have to have surgery. However, if you have pain,
Right.
I'll guide you. I'll guide you. And what I always caution people is just because you're seeing me doesn't necessarily mean surgery is the results. I'll be the
Right.
quarterback. So you have pain and you're not quite sure what to do. Come see me. I'll be the quarterback. I'll get you to the right physical therapist. I'll get you to the right pain management specialist. And if you have a surgical issue, I'll take care of that as well.
That's great advice. I want to thank you for taking the time from your busy schedule to join us today and talk to us about the back and the spine. I learned a lot, and I'm sure the audience out there has as well. So I really want to thank you very much.
Thanks for having me. I enjoyed speaking with you. Thank you so much.